Good day. Welcome to the Pulmonology Module Part 2. I'm Dr. George Maravillosa, a pediatric pulmonologist, and we will be discussing sleep disorders in children. Sleep breathing disorders is not uncommon in children. While most commonly happening in adults, this could also happen in children. We can define sleep breathing disorders into two types: obstructive sleep apnea and your central hypoventilation syndrome. OSA is an abnormality in the neuromuscular control of the upper airway patency, while central hypoventilation syndrome or CHS is a deficiency in the inspiratory drive. Therefore, it is somehow neurologically connected. Obstructive sleep apnea is an upper airway collapse during inspiration. This happened during an rapid eye movement sleep disorders. It's triad composed of loud snoring, difficulty breathing during sleep, and sleep-related breathing pauses. There are different anatomic factors predisposing to obstructive sleep apnea. These are as follows: adenotonsillar hypertrophy, mycognathia, Down syndrome or trisomy 21, presence of craniofacial abnormalities, history of allergic rhinitis, upper respiratory tract infections, choanal atresia, and nasal foreign body. Others include deviated nasal septum, chronic use of nasal decongestant, presence of velopharyngeal plop, patient who undergone cleft palate repair, macroglossia, and obesity. Clinical findings in pediatric OSA could be divided into sleep-related and during wakefulness. During sleep, a patient is known to be having a loud snore. There is difficulty breathing during sleep. There are pauses of breathing reported by parents. There is sweating during sleep, and the patient is restless, and there is frequent awakening. While during wakefulness, the patient is noted to be mouth breathing. There are adenoidal phases, presence of chronic rhinorrhea, and difficulty swallowing. The sequelae of obstructive sleep apnea includes cor pulmonale, failure to thrive and poor appetite, systemic hypertension, frequent respiratory infections, hypersomnolence, hyperactivity, pathologic shyness and social withdrawal, and delayed development and learning difficulties in young children. To diagnose obstructive sleep apnea, we need to answer these three questions. First, does the child have clinically significant sleep-related breathing problems? Second, is this problem due to an upper airway obstruction? And third, what is the site and mechanism of the obstruction? But some people would question, why is there a delay in the diagnosis of pediatric sleep apnea? These are the reasons why. First, there is due to the absence of awake symptoms reported by the parents. There is also failure to obtain a good sleep history. Snoring and restless sleep are considered inconsequential by the parents or relatives. Severe symptoms appear during REM while the parents are also asleep. Or a child may not generate a loud, disrupting snore than that of the adults. Polysomnography remains the gold standard of diagnosis of obstructive sleep apnea. This allows quantitation of the number and duration of the obstructive apneas, and the severity of partial airway obstruction and the degree of hypercarbia and hypoxemia. This is an example of a polysomnographic studies. There are graphs coming from the ECG, EMV, and also of the tidal breathing of the patient. Other modalities such as lateral neck radiographs, upper airway fluoroscopy, sleep histories and questionnaires, and ECG can also be used, but these are less sensitive and specific to diagnose obstructive sleep apnea in children. Treatment of OSA or obstructive sleep apnea composed of tonsillectomy or adenoidectomy for patients who have severe hypertrophy of the tonsils and adenoids. Putting up or using the nasal continuous positive airway pressure or NCPOP for obese patient, weight loss management and nutrition, and to severe extent, the use of tracheostomy. Next, we discuss the central hypoventilation syndrome or CHS. CHS may be congenital or acquired. For congenital, it may be mild to moderate in severity. Age of diagnosis is variable. It's commonly associated with Arnold-Chiari malformation. The image shown on your right side is an Undin's curse. This is the most common form of congenital hypoventilation syndrome. While the acquired central hypoventilation syndrome is or can be related to structural lesions in the brainstem or trauma brought about by infections, presence of tumors, or infarct or due to asphyxia. Diagnosis of central hypoventilation syndrome is also the same with that of the obstructive sleep apnea. The use of polysomnogram shows the inability to increase respiratory frequency, tidal volume, or both, which differentiate it from obstructive sleep apnea. Treatment includes oxygen supplementation, theophylline, mechanical ventilatory support, nasal CPAP, and sometimes diaphragm pacing. In summary, we have discussed the diagnosis and management of common sleep disorders in children. Please be ready for a case discussion or on our assigned day. I encourage you to read further about these three topics we have discussed in your Nelson's textbook of pediatrics. Thank you.